All right, the last part of this unit will be all about scoring respiratory events. Let's talk about how to measure how long events are. And don't worry if you don't understand the words at first. I have an example to show you what I mean. We measure respiratory events from the lowest point, or nadir, before the event occurs, all the way through the event and to the nadir before the next normal breath occurs. We score apneas with a thermistor, hypopneas with a nasal transducer, nasal pressure transducer, unless the patient is on CPAP, for which we would use the CPAP flow signal. If any of these sensors fail, you may use alternative sensors. Sometimes it's hard to know what the baseline respirations look like, maybe because the breaths are all different sizes. You can terminate a respiratory event or end it when there is obviously bigger breaths or an oxygen resaturation of at least 2%. When you're actually scoring a study, you'll simply click the mouse where you think the event starts and drag to highlight where you think the event ends. This is a good example of how to measure events. The thick teal line here indicates normal breathing. It starts at the nadir and it ends at a nadir. In this case, the nadir is at the end of an exhalation. The red bracket begins at the nadir before the event starts and ends at the nadir before the next regular breath. This is the correct way to score event duration. It captures the entire time of respiratory disturbance and is standard, or everyone does it the same way, making it a more consistent way of scoring. Obviously, we're only interested in what the patient does while they are sleeping. However, there are cases where there may be a few brief moments of sleep in an epoch that would be staged as wake, but the event goes into the next epoch, which would be staged sleep. It's kind of like scoring arousals in sleep. This is allowable. If an event starts in an epoch of sleep but ends in an epoch, if an event starts in an epoch of wake but ends in an epoch of sleep, it can be scored. These are seen a lot of times with people who have a lot of events, and they happen so often that they don't get a lot of sleep every epoch. Also, whenever we have a patient on supplemental oxygen, that may give imprecise desaturation values. So we should always document when we think we see a hypopneas, but there are no desaturations because the oxygen may be to blame. Before we can really discern normal from abnormal breaths, let's look at normal breathing. This is a 2-minute window where it's got 4 epochs. It's got those 4 big blocks of non-REM sleep and normal non-REM breathing. You can see an even and rounded morphology with the appearances. The effort belts are in sync and deflect with parallel motion. They're not paradoxing or not going against each other. They're going up and down at the same times. There's no desaturations in the oxygen sensor. I don't see a snore microphone, but snores can also show signs in the effort and airflow, so I don't think there are any. This is normal sleep. REM respirations are a little different than non-REM. When we are in phasic REM, or when irregular respirations or rapid eye movements occur, our lizard brain is in stealth mode for hunting or survival. We put all our energy into visualizing the environment, and we slow our breathing. Think about when you get scared or excited. You may take in a quick breath and then hold it. That's your limbic system activating. Your lizard brain is going into protect mode, and that's normal. As long as there are no arousals or oxygen desaturations, these central hypopneas are okay. So like right here, this is the airflow, and it goes down during phasic REM. Here's a little bit more. You can see the effort belt goes down a little bit, and then it comes back. That's normal. To score any kind of apnea, which means a cessation or there's no breath, you must have 2 things. The airflow signal has to decrease by at least 90%, so we're looking for a close to flat line in the airflow. And second, the event has to last at least 10 seconds from the first irregular or missed breath to the last. There's no desaturation criteria. We score apneas as obstructive if there is continued or increased effort in the belts, if the effort is paradoxing, or if there is snoring prior to the event. Usually, apneas are obstructive to the point that snoring doesn't even come through. That's a good way to know if it's truly an apnea or not. Central apneas occur when the brain says, "Oh, I don't need to breathe right now," and there is no effort at all, just straight lines. A mixed apnea is when there are two separate components to the event. One is central and the other is obstructive. Typically, mixed apneas begin with a central component and end with an obstructive component. You must have no effort and then a change to effort seen for a mixed apnea event. There is no time requirement for the central or obstructive component or which occurs first. The entire event just must last at least 10 seconds. Let's look at the purple shaded box right there. Above it, it looks like non-REM. Lots of chin tone. I don't see eye movements, but this isn't a lot of alpha or PDR. And there might be a K complex, maybe. This blue line is the thermistor. Right above that is the snore microphone. See these snores? They go away right here. There is no breath coming in and out. You see this up and down for the thermistor? That is a flat line. They're not moving any air in and out. The airway has closed. This could have been scored a little earlier because these qualify for hypopnea breaths, and you can include those. So this whole thing could have been scored in apnea. We'll go over that rule later. I also would have made the arousal more right here because that's when the big breath happens and you have PDR right there. But this was just scored where it kind of looks obvious. The problem with that is not lining up with this, and so this is not being counted towards an obstructive arousal. It's just a spontaneous arousal. So that'll be underscored. This is a study I ran years ago. This is pretty amazing because this patient is on bi-level because we had maxed out CPAP pressure at 20 centimeters. So right here it looks like we're at 25 over 20 centimeters. Despite that high pressure, check out the middle of this 2-minute window. The CPAP flow flatlines. We're using the CPAP flow because she's on CPAP and you don't wear a thermistor or nasal pressure transducer. And check out the effort. We're going in, out, in, now. They're going in and out and pointing in. This is paradoxing effort. When the patient finally arouses, she takes in a huge breath, and it's so huge that it makes a big snore. That's the snore microphone right there. I never found out what was wrong with this patient. It was a lady, and she wasn't even like giant or anything. There's just something going on with her anatomy that has really bad apneas. Remember the difference between central and obstructive events. Obstruction means the throat is closed and the patient can't move air even though they're trying. Central means the brain is saying not to breathe. Therefore, you will not see any effort to breathe. The airflow signals for apneas all look the same because there is a cessation of breath in both circumstances. The effort is what's different. Here we see 3 straight lines: the abdomen, the chest, and the airflow. As long as the apneas are 10 seconds long and the airflow has decreased by 90%, you don't have to have a desaturation or an arousal. Although you want to score arousals and desaturations associated so they're reported correctly. So sometimes central apneas can occur after a sigh. If you see at the beginning we have normal breaths, this is a CPAP. No obstructions, the belts are in sync and they're normal, no snoring. Then 2 or 3 times bigger breath in and out, and then a central apnea. There was an arousal there, and so sighs are normal physiological features during sleep. When we sleep normally, our lungs can get stiff and stagnant because there's no variability in what we're breathing. We're just in and out a little bit, in and out, in and out, in and out. So we're not stretching it very much. The tidal volume, how much we breathe in and out during sleep, is relatively low compared to wakefulness. So a sigh stretches out the lung anatomy. It's also speculated that this is a function of carbon dioxide processes in the body, and this is like a reset. So why don't we no breathe afterwards? Well, we just took in a big breath that might have been 2 or 3 times bigger than a normal breath, so the body doesn't really need to breathe again because the gas exchange had increased geometrically. Also, it's somewhat normal for essential hypopnea or slightly shallow breaths to occur during sleep onset. So the question is, when do you score these? Well, some providers want you to score absolutely everything that qualifies an event, physiological or not. Other doctors don't want these to be scored because they will elevate the AHI inaccurately. It's those to the provider. It's the provider as to whether you score these or not. I have a personal rule for scoring onset centrals. If they happen 3 times in a row, I start scoring on the third event and all the events afterwards. It's kind of arbitrary, but it was a consistency thing that a lot of patients will have 2 and then they'll get over it and go on. So on the third one, I would start to do it. And I would also document why and when I started scoring like that so the doctor knew what I was doing. Here is a normal sigh without a central apnea or arousal. Right there. It's just a big breath. No big deal. The sighs may show up every 15 or 20 minutes of stagnant breathing in healthy individuals. This patient was on CPAP, and when they start to sigh, that's a clue that the pressure has been set close to perfect. Here are mixed apneas. Notice there are two components in the effort. That's what counts. The first is central, no effort, and then it ends trying to breathe right there. Throughout the entire event, even when they're trying to breathe, there is no airflow. And then there's an arousal and a desaturation. No, it looks like 93 to 89. Neither of which are they're not required to score it, but they are associated for their importance, so they're still really important. These are different. There are different reasons for mixed apneas, but we can't really nail it all down. I've seen it the most when I have a patient on CPAP and they're over-titrated or I've given them too much pressure. Too much pressure induces central apneas. Hypopneas are next. Hypopneas translate into under or below, and pnea, which is breath, under breathing. The difference in the airflow signal between apneas and hypopneas are 90% signal loss, and hypopneas are at least 30% signal loss. You can figure out roughly what 30% is if you try and imagine what a third of a normal breath would look like. If you can look closely, you can tell when the breaths become smaller. It's not a totally precise measurement, but we're looking for a signal drop, just not as much with an apnea. The other difference between hypopneas and apneas are hypopneas require at least either a 3% oxygen saturation or an arousal. You can have either one or both. This is the classic ASM way of scoring hypopneas. At least 30% signal loss associated with an arousal or a desaturation. That is the recommended rule 1A. But evil has set in, and there is now a rule 1B, which is acceptable. The difference between the two rules are, with 1B, there must be a 4% desaturation, period. There is no arousal at all. Doesn't matter if they have one. You just have to have that 4% desaturation. And this is specifically for Medicare and Medicaid patients. You still have to have at least 10 seconds in duration. So this makes the AHI underscored because it's harder to get a 4% desaturation than a smaller 30% desaturation or just an arousal. They will, however, you can still call these RERAs, which we'll talk about later, and that'll be reflected in the RDI, or the Respiratory Index, Disturbance Index. The manual says it's electable or optional to specify if hypopneas are obstructive, central, or mixed. Some providers don't require a designation, but I am telling you that you should know the difference, because there is a difference in the origin of central versus obstructive events, and that should be considered for therapy. Like I said earlier, if CPAP is over-titrated or there's too much pressure, the patient might start having central events. If your policy procedure says to increase CPAP for all hypopneas, the centrals will get worse. That's why it's important to designate centrals and obstructives and mixed. The rules for scoring obstructive hypopneas include signs of obstruction, continued or increased effort, deflections in the snore microphone, paradoxing effort, or flattening of or flow limitation in the nasal pressure transducer. The manual says to score a central hypopnea if none of the evidence for obstruction that we just listed is there. So that would mean decreased effort, no snoring, no paradoxing. The breath should not have flattened or flow limitation at the peaks. The peaks should still be round, but the breath should just be smaller. Mixed hypopneas start with no effort for the central component and followed by effort for the obstructive component. There must be a 30% signal drop throughout both components. You'll hear the term flow limitation a lot, and it's all about the peak of the breaths. So check these out. They look like they have a little cup or a little cave on the top. See that? These little cups. This is supposed to be a nice rounded peak, but these are little cups. And so that's like they're only taking a half breath in. You can also see little snore deflections. If these breaths get too small, they will qualify for hypopneas if they are associated with an arousal or a desaturation. To compare, there are a couple here's a nice normal breath right there. See, that peak is not going up there. We had this at the beginning, and we were talking about where to start and stop scoring the event. We start at the low point, or nadir, before the first affected breath occurs, and score all the way up until the nadir after the last affected breath, or just before the normal breathing recurs. Let's measure these a little bit with our minds. If we compare the size or amplitude of the normal breaths versus the smaller breaths, I'd say that's close to about half the size of the normal breaths. Half the size is 50, so that signal flow would more than qualify for a 30% hypopnea. The next two breaths under the airflow is effort. And in fact, it's very subtle, but you can see, boom, 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 the abdomen increases effort very slightly for each breath. They look like stairs going up, a little higher each time. We'll see another event that if there is no desaturation, but there is decreased airflow and this kind of effort that increases, we could score that as a RERA, or a respiratory effort-related arousal. Speaking further on this specific example, if it's obstructive or central, what do you think? We don't have a lot of evidence, but the top airflow looks like it's cupping or flattening, and that resembles flow limitation. Without the luxury of seeing a snore microphone or any other hints as to central obstructive, I'd still say this is obstructive. If it weren't for those little flattened tops and the increase in effort, I'd say that this would have been central. Here's a decent obstructive hypopnea. In fact, the ending looks like it might qualify for an apnea. Check out the beginning of this record. These normal breaths appear to have paradoxing effort. See, they're going in together and then kind of out together, and there's a little notch there. In together and out together. Sometimes they don't, though, during those normal breaths. And when the obstruction starts, when this airflow starts happening, they're in sync. So probably what happened is, I think the in sync effort at the beginning is really or at here, is really paradoxing. Sometimes the airflow signal can just look strange, but if you have like those little dips there, that's flow limitation, and that's usually going to be accompanied with, there you go. Here's a little flow limitation, and you have this little in the chest belt. So if you have other evidence pointing towards flow limitation, you can confirm your suspicions that much more. Like in the effort, it's not smooth and sinusoidal. It's got extra bumps in it some places. If you take a breath in and halfway through, close up your throat while you're still trying to breathe in, you'll notice your torso jumps a little bit. In fact, if you hold your breath and push your stomach muscles in and out, you should notice your chest is moving opposite from your abdomen. This is paradoxing or paradoxical effort. So when you see little bumps in the effort, try and figure out on yourself what would make that happen. If you see a little breath and then a big breath, try and feel what that feel. What do you think that would feel like? Same thing with the chin tone. Have you ever heard of progressive relaxation? That's where you try and relax every muscle in your body, starting from your head going down. If you consider all the muscles that are around your lips and chin and jaw, it's tough to naturally relax them. But if you learn how to flex those muscles for a few seconds and then let it go, that's what it feels like to relax them. Making a firm chin with these electrodes makes it look big, like a big black line. So if you think about how all these sensors work, you can figure out what you're looking at. Here are a few obstructive hypopneas. Compare the normal breaths, and then they get smaller. And then right there, I'd say it starts. Right there, I'd say it stops. I'd say it starts right here because that's still got some amplitude to it. And then right there, it looks like it's about halfway down. These occur with arousals and desaturations. They even have leg movements. But you don't score those as they are happening prior to or after a respiratory event. In this case, the leg movements are probably part of the arousal mechanism, literally kicking the body awake and saying to breathe. This is a 3-minute window, so there are 6 epochs. The green highlights are obstructive hypopneas, and this brown, reddish kind of looking signal are nasal pressure. That's where you score hypopneas. Compare the decent breaths when they're awake and then when they fall asleep. That's much smaller. And then they wake up and take in big breaths, and it goes away again. They have signs of flow limitation. However, there is no snoring and no paradoxing effort. They really don't even have any qualifying desaturations. Not for those events. And I remember this study well. It was a middle-aged lady, she was normal, who wasn't showing signs of sleep apnea because she did all this. Because of all the arousals, I scored them all, and I ended up splitting her. And to both her and my surprise, on CPAP halfway through the night, it totally fixed her. Very strange-looking hypopneas, but you can tell that the airflow does go down significantly. Here's another 6 epochs from that study. There are better instances of actual light snores here, and you can see them poking through even with the nasal pressure. There are some slight desaturations, but I've got it set so that I could see them very well, but these aren't 3%. Here are good examples of central hypopneas. These appear to be occurring in REM. Usually we expect some central activity in phasic REM. However, this looks pretty rough because these are some pretty tough desaturations. That's 4%. But, and I probably score these because oxygen desaturations in REM have been known to score headaches, and you're just not supposed to desaturate like that. The peaks are all still rounded. They look like normal breaths. They don't look like they have flow limitation. They're nice and rounded. They're just smaller. They are not blunted, flattened, or cupped. The effort belts are still in sync. They don't paradox. Classic central hypopneas, which would be scorable for Medicare and Medicaid because These desaturations are 4% or more. There's something about REM that oxygen can be a real tough cookie to solve, much more so than non-REM. It's probably a combination between the different part of the brain that controls breathing during REM, as well as the paralysis of airway muscles. If there's an event, all right, here's that rule. If there's an event that begins as an hypopnea, but has at least 10 seconds where the airflow matches an apnea, you can score the whole thing as an apnea. Start where it would either the hypopnea or apnea would start and then end. For instance, the top figure includes the hypopnea and apnea portions in one scoring swipe, so score the whole thing as an apnea. In instances where a patient is having hypopneas or with just arousals or 3% desaturations and aren't scorable because of Medicare or Medicaid, you can score them as RERAs, respiratory effort-related arousals. Also, there is the added allowance that the airflow signal doesn't have to match 30% minimum airflow signal loss the whole time. The true RERAs that occur are all about the effort. The effort continues to increase and increase until an arousal occurs. We do expect to see some sort of flattening or signal loss in the nasal pressure, but there is no specific requirement. Again, these events do not contribute to the AHI, the apnea-hypopnea index, but it does contribute to the RDI, the respiratory disturbance index. Some insurances don't consider the RDI as serious as the AHI and don't consider it a qualifying value for therapy. Nothing gets in the way of trying to help patients more than insurance. Here's an okay diagram of a RERA. You can see the top signal airflow and the red line, which outlines the duration. That it's stunted, but that might be 30%. I can't really tell. They are smaller and flattened, though. The effort, though, especially in the abdomen, shows a staircase-like progression. And I've got 3 of those there. The other line at the bottom is supposed to represent a static oxygen desaturation. So that's like the pulse oxygen, meaning no desaturation. This would be an instance of when a RERA could be scored. There has to be an arousal here. Some physicians do not require text to score RERAs. They would rather them be documented only. I worked for a pediatrician that did not think RERAs were exactly a terrible thing, so they preferred me to just document when I thought they were occurring. Hypoventilation, almost like a hypopnea, but this is also translating into under or below breathing, but for a different reason. Hypoventilation is when a patient is unable to move enough air to provide adequate gas exchange. There are a couple of reasons for this, including young, underdeveloped lungs, some respiratory issues, morbidly obese patients, and patients with neuromuscular disorders like ALS or multiple sclerosis. These patients' lungs are not able to do the job efficiently enough to breathe off the CO2. CO2 is the primary respiratory driver. Too much CO2 means you have to breathe off more of it. It's the CO2 that builds up and makes your brain wake up. Hypoventilation is scored on the values collected with a CO2 monitor, which we call a capnograph. Capnographs measure CO2 in units called millimeters of mercury, also seen as mmHg. Capnographs can also collect CO2 data 2 ways. The most common is with the airway and a cannula and end-tidal CO2 monitoring. It's called end-tidal because we are measuring the CO2 content of breaths at the end of an exhalation, which is the end of a tidal breath. The other is transcutaneous CO2 monitoring, and that involves a sensor that just sticks on the skin. It is a heated element, so it has to be moved every couple of hours, or it may burn the patient's skin. These are TcCO2 for transcutaneous and EtCO2 for end-tidal. We score hypoventilation if the CO2 values are higher than 55 millimeters of mercury for at least 10 minutes. Or we score when there is at least a 10 millimeter of mercury increase in CO2 during sleep to a value exceeding 50 millimeters of mercury. When we do biocalibrations to make sure all the sensors for the study are working, we have the patient laying supine so we can compare the CO2 values to this baseline. Capnography is not required for any patients other than pediatrics, but it's good to use on those with neuromuscular dysfunction and those with a BMI over 40. Hypercapnia is the condition of having too much CO2, and that is caused by hypoventilation. Here we can see the capnograph is consistently averaging between 54 and 55 millimeters of mercury. This is hypoventilation. I personally haven't seen hyperventilation on children, but I have seen hypercapnia in morbidly obese patients. It's hard to really capture because these patients usually are continually arousing from obstructive events. The last respiratory pattern we'll talk about is Cheyne-Stokes respiration, also known as CSR. These are bouts of gradually increased breath amplitude and gradually decreasing breath amplitude. If you know music, you may have heard about dynamics or crescendo and decrescendo. P means quiet, F means loud. When we crescendo, we get from soft to loud, and decrescendo means getting loud to soft. The exam loves to use this terminology of crescendo and decrescendo as well as a waxing and waning of airflow. We score Cheyne-Stokes respiration two different ways. We can have at least 3 consecutive central events, either apneas or hypopneas, which are connected or separated by a crescendo and decrescendo change in breathing amplitude. Each one of these breath patterns from big to small last longer than 40 seconds each. Or we can have at least 5 central events, apneas or hypopneas per hour, that are associated with the crescendo-decrescendo over at least 2 hours of recording. The cycle length is measured from the time of the beginning of a central apnea to the end of the next crescendo-decrescendo respiratory phase, or start of the next apnea. Central apneas that occur within a run of CSR should be scored as well. So, these signals are airflow, two belts, and pulse oximetry. As you can see, the breaths start out gradually into another central apnea. And then it's small, a little bigger, bigger, and then it gets smaller again until it gets nothing. So you can consider all of these one scoreable event as CSR, but you can also go back and score the individual central apneas as well. Central apneas and hypopneas are components of the overall CSR breathing pattern. We start scoring at the beginning of the central apnea and score all the way through to the end of the decrescendo before the next central apnea. You can see this in that blue box. This is a cycle of CSR. And guess what? That's it for now. But those are the very basics of staging and scoring sleep. And as far as the basics go, that's really all there is to it. It's just more about recognizing these patterns in real time when you're looking at a study as it goes by. All right, we're hammer this stuff into your brain because all these numbers and qualifying requirements, you got to know it. You got to know it in your head, and you got to poop it out right when that exam happens. All right, so we'll talk more about all this stuff later. Please email me, text message me with concerns you have if you don't understand things. I'm happy to talk to you more about them. All right? Happy studying.